Hello everyone, welcome back to our channel, The 20th Notebook. Today is day 2 out of 60 of Challenger edition for NEET PG 2025. I hope you all follow the schedule for the next 60 days and get to make the most of our My 20th Notebook. Starting with the first topic for today, flipping on to the page number 13 from our 20th notebook, we begin with IB anesthetics. So what basically you need to remember in IV anesthetic is the general properties, which include depression of myocardium and decreased cerebral blood flow. Exceptions being ketamine, which acts as a sympathomimetic, and etomidate, which is cardiac stable and hence preferred in rapid sequence intubation. So what are the four drugs you need to remember? Thiopentone, propofol, etomidate, and ketamine. So just two things of each of these drugs would help you retain them for a long time. Thiopentone, the most important thing you need to remember is it is also an anticonvulsant, and if you give it directly to the artery, if you inject it directly through artery, there is vasospasm. One important side effect you need to remember is it is contraindicated in porphyria because of its injection into artery causing vasospasm and pain. It is contraindicated, or whenever we give the brachial plexus block, you should not remove the needle because of its close proximity to the adjacent arteries. So propofol, what would you remember is the injection is painful whether you give it subcutaneously or IV. And one important thing you need to remember is it is also a strong antiemetic. Side effect wise, you need to remember the patient might present with propofol infusion syndrome, where they might give you a case scenario of a patient presenting with metabolic acidosis on EBG, and urine wise on Foley's bag you can see either green or red urine because of its property of rhabdomyolysis. Okay. Next, you need to remember in etomidate that it is cardiovascular stable as previously told. Also, it causes highest risk of postoperative nausea and vomiting, and you should avoid this. Why it is avoided is because of its postoperative nausea and vomiting, and also the property of adrenal suppression and convulsions. Ketamine, the most important thing is it is also painless, but it causes dissociative anesthesia. As soon as you hear this word, it has to be ketamine. And important thing to remember is ketamine is also contraindicated in epilepsy, just like thiopentone. Moving on to the next part, inhalational anesthetics. In inhalational anesthetics, they increase cerebral blood flow and ICP also, but they act as respiratory and hepatic depressants. What you need to remember among these is the four drugs: halothane, isoflurane, sevoflurane, and desflurane. Just remember, I will talk about MAC and potency of each of these drugs later, but in halothane, you need to remember two things: that it, because of its fruity smell, it is a smooth inducer, and side effect wise, halothane hepatitis is an important side effect that you need to remember. Isoflurane, though it is most commonly used, it has an irritant induction property, but it is stable and hence minimally affects renal and hepatic function unlike other inhalation anesthetics, and hence it is most commonly used. Disadvantages wise, you need to remember the coronary steal phenomenon, which is common with HIDES drugs, which I will be talking in pharmacological section. I being isoflurane. Sevoflurane, you need to remember it is also sweet and hence pleasant induction and inhalational agent of choice in pediatric anesthesia. And desflurane, what you need to remember is it is also irritant, but because of its fast onset, it is used in daycare surgery. So what exactly you need to remember in MAC and potency is that MAC and potency don't go hand in hand and are always inversely proportional. Maximum MAC means that the drug is least potent. MAC, you know the full form, I guess. It's minimum alveolar concentration, and nitrous oxide has highest MAC because it is the least potent drug, and out of the drugs which are currently used, halothane is the most potent drug. Just remember, halothane is the most potent, and we have nitrous oxide as the least potent drug. Just 1 or 2 points about nitrous oxide. Nitrous oxide, what you need to remember is that it is non-irritant, but it also has one important side effect, that it expands in any closed cavity, and hence is contraindicated in what surgeries? Pneumothorax, in patients with pneumothorax, lung cyst, or ear, middle ear, inner ear surgeries, tympanoplasty, and volvulus. And there are some terminologies that you need to remember, being Fink effect, second gas effect, and Poynting effect, purely for ionized point of view. I don't expect it to be asked in NEET PG. And next, going on to the next important thing, flipping onto the page 17 of our notes, opioids is single most important drug-based question from anesthetics, and you have to remember the actions of mu and kappa receptors and the classification of opioids. But the important individual opioids whose points you need to remember is fentanyl, remifentanil, and pethidine. Fentanyl, you remember that it is cardiac stable and is used for rescue analgesia. Remifentanil being used for daycare surgery, and pethidine, the most important point is that it is used for post-op shivering. Moving on to the next point of muscle relaxants, you need to remember two important things: classification, depolarizing and non-depolarizing muscle relaxants. In depolarizing, just remember succinylcholine. In non-depolarizing, remember two important classes: steroidal molecules which contain steroid, or benzyl isoquinoline. So in steroidal, why you need to remember this classification is because steroidal ones can be reversed by Sugammadex, while benzyl isoquinoline is not reversed by Sugammadex. So just remember benzyl isoquinolones, which important ones which we use generally are Cisatrra and Astracurium. They just important thing is these two drugs are not metabolized by kidney or liver, and are hence kidney and liver, and hence are safe in both renal failure and hepatic this cirrhosis or other conditions. So why is because they are eliminated by Hoffman's method, Hoffman's elimination, which we will be speaking about in pharmacology. Other than that, all your pancuronium, bicuronium, rocuronium, piperaquirium are all steroidal drugs. Curonium, so anything with ON is definitely a steroidal drug. Just remember, when steroid is on, the patient is on, because Sugammadex can definitely reverse even if in case of high dosage. In succinylcholine, what you need to remember is prolonged blocks and reversal. You need to remember the abnormal pseudocholinesterase, which is diagnosed by Debouquin number, purely from INI point of view. Other than that, you other two low sodium pseudocholinesterase and phase 2 block can be skipped. Next is the agents of choice for everything. You just remember that in agents of choice, I have given certain mnemonics, but three important things among all this is the hepatic agent drugs which are used in hepatic diseases, agents of choice in hepatic disease, then cardiac disease, and in daycare surgery. So hepatic disease, as you already know, the mnemonic is PAS. The first PAS metabolism occurs in liver, so just remember the PAS. P being propofol, then atracurium, and sevoflurane. Cardiac wise, you just remember, patient who has cardiac disease will panic and tell, oh, I have cardiac disease. So remember, I have IVE, which is isoflurane, vicuronium, which is a steroidal drug again, as I told, and etomidate. Daycare surgery wise, just remember I had a mnemonic called Pro Rani and Desi Mid. So Pro being propofol, Rani is basically Remi, Des being desflurane, and Mid being midazolam. Moving on, you need to remember local anesthetics classification being esters and amides. Amides in the name will have two eyes, that's all. Don't need to buy it everything, just remember this mnemonic and move on to the next important thing. Also remember the shortest acting drug in esters being chlorprocaine. Next, you need to remember certain specific side effects. This is kind of important and I expect it to be asked in one of the exams, either INI or NEET, especially methemoglobinemia. And last, which is local anesthetic systemic toxicity. Methemoglobinemia, just remember Prelo and benzo. And the last, which is local anesthesia systemic toxicity, you just remember that it can happen with any drug, and the most important treatment for this being 20% intralipid. Earliest sign being perioral numbness. Okay, next, just going on to the order of blockade is one important thing that you need to remember also, which I have not included. In drug doses, nothing much to remember except for lignocaine concentration, which is used in nerve block being 1%. Drug dosage of lignocaine 1% in nerve block and 2% in epidural. Rest all is skippable. Epidural is 2%, 1% in nerve block, spinal is 5%. Bupivacaine you don't need to remember. Remember EMLA, which was recently asked. Eutectic mixture of local anesthetics is made by lidocaine and prilocaine, equal mixture of 2.5%. This is because melting point of this combined substance is lower than melting point of individual substance, and hence as soon as you apply this, the structure will melt and the mixture will melt and it will be easily absorbed by subcutaneous surface. Just remember that important diagram of spinal cord, the order of piercage of each of the structure. Other than that, central neuraxial blockade, you just need to remember the dura cutting and dura splitting needle. Dura cutting, if you remember, that will be enough. Cut is quinque, C sound together, quinque and cutting. Splitting will be sprout, SP and tohoi also, but just remember these important things. Then in LP you just need to remember the order of blockade. Always small c fibers are the ones which get easily blocked. So then temperature comes. So small c fibers and temperature are the important order. Then just remember in epidural block versus spinal anesthesia, the important things. Just remember that epidural has rapid onset sensory block. However, spinal has rapid onset sensory block, while gradual onset happens in epidural, and it may also spare the motor and is hence preferred in labor blockade. Also important thing is it causes less hemodynamic disturbance. Next, moving on, in critical care anesthesia, which is the single most important topic in anesthesia, which or it is a medicine and anesthesia overlap point. Just remember the algorithm for BLS in adults and in children. Just remember, always they will test your scene safety, or next thing, how we will activate ERS. If one person is there, then he will shout for help and then activate ERS. If there are two persons, one person will after verification of scene safety, of course, one person will start CPR and the other person will activate ERS. So just remember this thing. And in children, just remember it is the same as adults, unless you have not witnessed the collapse of the patient, where you have to start for CPR for 2 minutes, try to revive the patient, and then you can activate ERS. ERS is what that you have to remember. Okay, moving on. Next, adult versus child CPR. The important order you need to remember is the compression per minute remains roughly the same, 100 to 120, staying alive. is one song which helps, whose beats match with the frequency of the compressions. Remember 5 centimeter is minimum the depth of compression. Techniques for children, infant and adult is different. Just go through that once. You have to keep it on the lower, 2 hands on the sternum in adults, circle them in children, and 2 fingers or a thumb is enough in infants. Another thing you need to remember is the compression ratio. Single rescuer or 2 rescuer, compression is to ventilation in adult remains the same, 30:2. However, in child, if there are 2 rescuers, because of their rapid breathing capacity, if there are 2, then only go ahead with 15:2 or else go back to 30:2 ratio. Compression rate will always be the same. They might trick you in that. Drug therapy is what I have given. Important thing, just remember the dosage and also the route of injection and when do you use that. And some important maneuvers: head tilt, jaw thrust, chin lift, and recently asked one rescue position. Okay, these are important things which you need to remember in anesthesia. Okay, other than that, I have covered most of the stuff of anesthesia in 15 minutes in each session. Also remember, you don't need to do anything more. Don't try to do anything more for a short subject. Just leave it whatever you have seen in our 20th notebook. That's all. You don't have to study all other stuffs. I have given you some authors pick being Aldrich score and stuff which are not covered in our 20th notebook. Just go through them once also, and then remember the color coding. Pink and blue, just remember pink and blue is your savior. Pink blue topics do not skip for the last week. Okay, yesterday's MCQs you might have observed. What were the MCQs? I'll go ahead with today's MCQs first and tell you the answers of yesterday's MCQs at the end of the session. So okay, this question, in interscaling approach, this is basically, there are a few approaches to block brachial plexus, so you just need to remember them. So in interscalene approach to brachial plexus, there is one important point that it does not provide surgical anesthesia in the distribution of one of the nerve. Which of them is the question? You just need to remember the table for that. So this answer, hope most of you know which is the answer. Then the question number 2, being tracheal intubation to assist ventilation is indicated when PaO2 is less than dash despite maximal oxygen therapy. Just need to remember the table when you need to give what oxygen support for the patient. Okay, so if PaO2 is less than a certain point, you need to go ahead with intubation. Hope you know the answer. Next, all of the following are potentially reversible causes of cardiac arrest, except this is a trick question. You need to think, and such questions usually take more than 1 minute. Save time for such questions. You might have never come across such questions. Just go through the options, and whichever seems the most plausible one, you need to choose that one. I'll give the explanation in the next session, of course. Next important thing you need to know is neonates born to mothers receiving prelocaine for epidural anesthesia are more prone to develop what of the following. So I talked about local anesthesia side effects, and among them only one of them had, you just need to remember this table, and only one of these options is present in that side effects. So this is clear. They just want to trick you and give a different case scenario, and you might think, oh, what it might cause to the fetus when given epidurally. Okay, just remember that side effect remains the same whether being adult or a baby. This I have included because they had recently asked a similar question for a CNS drug in a patient, in a mother who received that CNS drug. Okay, next important thing is, in patients receiving low molecular weight heparin, neuroaxial blocks should never be performed, should be delayed by 12 hours after administration, should be delayed by 12 hours, can be done any time depending. So this is another trick question where you will need more than 1 minute to answer. So save time for such questions and hope you know the answer. We will go to the yesterday's questions. The first question for yesterday was, which of the following is associated with lower incidence of post-operative nausea and vomiting? There is a score for that. You don't need to remember that, but just remember that history of smoking somehow is associated with decreased incidence of post-operative nausea and vomiting. Everywhere else you think smoking will be responsible for something, but in this case it is causing decreased post-operative nausea and vomiting. Next important thing was in a person undergoing lap surgery for CO colon. You just need to remember which antihypertensive preoperatively in geriatric group was found to be associated with profound hypotension. The answer was ACE inhibitors. Whenever there is a pre-existing drug therapy related question, it has to be either ACE inhibitors related, ARB related, or it has to be related to your low molecular weight heparin, warfarin, or other anticoagulants or blood thinners. Rest of them don't come into the scene. For a patient of RTA presenting with ER with profound hypovolemia, what cannula is preferred? Just need to remember that whichever cannula has the highest bore, that will be preferred. And I hope you all know the classification of cannula depending on the color coding. Most of you know the mnemonic as well, I think. Just remember the answer that orange having the largest bore might help to transfuse most amount of drug in a short period of time. That's all for I think we had another question yesterday for one of them I had already told the answer, lapistrectomy. There was one IBQ based question which the answer was Tuhoy needle. Just remember that Tuhoy, Quincke is a cutting needle, Sprotte and Tuhoy are splitting needle. Just go through the questions, the images for these needles. You don't have any shortcut to remember them unless you have seen the images. Okay, that's all for today. Join tomorrow for the next session. I will complete it within 20 minutes again tomorrow. We'll have the next 13 to 14 pages. For those who have not bought our book, these sessions might not be very helpful to you. This is mainly for my students, the 500 students already who have bought the book. So this is for them. I want them to do as better as they can, the best usage of our notes. Okay. For others who want to buy our notes, just text us on our WhatsApp, which is given in description. Thank you for joining today. We'll meet tomorrow. Thank you.